Welcome back to AMC PrepLab. Today we're going to look at the topic of laryngotracheobronchitis, also called as CROUP. This guideline is taken from the RCH website, which is a standard used in pediatric cases for the AMC examination, both clinical and for the MCQ. As the name suggests, it's the inflammation of the larynx, the trachea, and the bronchi. It is usually triggered by a viral infection, which is most commonly caused by a parainfluenza virus or other respiratory illnesses such as COVID-19. This is a drawing of the upper airway of the human body. In CROUP, there is inflammation of the upper airway as mentioned earlier, which causes an obstruction to the airflow and causes many symptoms which I will be discussing later. The age group most commonly affected is 6 months to 6 years. Symptoms are worse at night. It is uncommon under 6 months of age and it's rare under 3 months. Therefore, consider alternate diagnosis if presented below 3 months or 6 months.
Get them to consider alternate theories.
The main precaution that healthcare providers have to take is not to distress the child further, as it will definitely cause worsening of symptoms. So things such as oximetry, blood pressure monitoring and throat examination is not required. Make sure that the carer is present with child. Include the carer when examining the child. There are certain conditions that increase the risk factor of developing severe CROUP. These are previous history of severe CROUP, pre-existing narrowing of upper airways, reduced airway tone due to pre-existing conditions like Down syndrome or other neuromuscular conditions. Now coming to the examination findings, there will be a characteristic barking cough, stridor, hoarse voice or cry. There may be associated widespread wheeze. There's increased work of breathing. As everything is narrow, it is harder to breathe. May have fever, but no signs of toxicity usually.
Jeez, dude, please don't be so freaking toxic.
This is a table to assess the severity of CROUP. This table is important as it can help guide us to the treatment. One thing to note is that we cannot assess the severity based on the loudness of stridor, as a soft stridor in the presence of worsening clinical picture may be a sign of imminent airway obstruction. The differential diagnosis for CROUP are anaphylaxis, foreign body in the upper airway, bacterial infections such as retropharyngeal abscess, peritonsillar abscess also known as quinsy, bacterial tracheitis, and epiglottitis. CROUP is a clinical diagnosis and investigation such as respiratory swab or nasopharyngeal aspirate is not required. X-rays and blood tests are not indicated in clinical presentations. Remember, don't cause distress to the child. For the treatment, make sure to keep the carer with the child. Room should be quiet and with moderate lighting. The child will adopt a position that is most comfortable for them, as that minimizes airway obstruction. Do not change this position as it can cause distress to the child. Usually no oxygen is required. If required, treat as severe upper airway obstruction or consider alternate diagnosis like anaphylaxis or asthma. The main drugs that we use are a corticosteroid, that is dexamethasone, and nebulized adrenaline. Dexamethasone reduces the inflammation and will lead to decrease in symptoms. Now in mild cases of CROUP, and if there's only barking cough present, no need to give steroids. If there is a history of stridor or risk factors are present, consider dexamethasone 0.15 mg per kg oral or prednisolone 1 mg per kg oral. Repeat dose following evening. If it is a moderate case of CROUP, give dexamethasone 0.15 mg per kg oral or prednisolone 1 mg per kg oral with repeat dose in the following evening. Now after that, if there is a good response, we can discharge home once stridor free at rest. If there is deterioration or if it is a severe case of CROUP, give nebulized adrenaline 5 ml of undiluted adrenaline in the ratio of 1:1000 and dexamethasone 0.6 mg per kg with a max of 12 mg either IM, IV or per oral. Following that, if there is a good response, repeat adrenaline dose if recurrence or severe respiratory disease. Consider discharge at 3 hours post adrenaline if stridor free at rest. If there is minimal or poor response, repeat dose of adrenaline, consider alternate diagnosis and escalation to senior or transfer to ICU. If there is life-threatening CROUP, don't hesitate to call your senior. Give nebulized adrenaline 5 ml of diluted adrenaline 1:1000, oxygen at 15 liters per minute via non-rebreather mask, and dexamethasone 0.6 mg per kg with max of 12 mg, either IM or IV. Antibiotics have no role in the uncomplicated CROUP as it is a viral etiology. Antitussives such as codeine have no proven effect on the course of severity of CROUP and may cause respiratory depression and increased sedation. Cold air below 10 degrees Celsius exposure might reduce severity in moderate CROUP. Consider transfer when no improvement with nebulized adrenaline, child requires repeated dose of nebulized adrenaline, or child requires care above the level of comfort of local hospital. Discharge when the child is stridor free at rest. Minimum of 3 hours observation after use of nebulized adrenaline if required. More than 3-hour observation for those who present overnight, have limited access to medical care, for example if they are away from the hospital, present with stridor more than once during the same illness, has risk factors for severe CROUP. To summarize the important points, minimize distress to the child as this can worsen upper airway obstruction. Involve senior staff early and consider transfer if concerns regarding worsening upper airway obstruction are present. For severe and life-threatening CROUP, use nebulized adrenaline and seek a skilled senior clinician for airway support. Less severe cases can be managed with corticosteroids alone. As always, if you have any doubts, leave them in the comments and I'll get back to you. Like, comment and subscribe, and I'll see you next week. Bye.